All right, everybody. This video is about your in-service exam. Okay. I say a lot of things. One of the things I say all the time is the best teacher you should ever have is yourself, and everyone needs to learn how they learn best. Okay. For me, I struggled a long time with test questions because the more I learned in the department and the more I read, the worse I was at test questions because I didn't match up. What my breakthrough was you got to approach these test questions just like a game, okay? Like it's a game, that's all it is. And like once you understand the rules of the game, it makes it easier to kind of figure out what they're looking for. So I came across this lecture. This is an old lecture. It's about 7 years old. It's a bunch of test questions that we're going to go through together. The other part of this video is I'm going to show you how I take tests. And it's just like everything else I tell you, like this is the way I do it. If you like it, great. If not, then like don't listen to me, but it might help you out as far as like your in-service goes. Also, I don't remember these test questions, so we'll see how many I get right. I'm pretty bad at tests. Okay, first test question. And again, like I always read it to myself, like not in my brain, like I read it under my breath because like when you hear yourself saying it, like it's totally different. Okay, so here we go. A 66-year-old male with a history of diabetes and hypertension presents to the emergency room department reporting a sudden onset of substernal chest pain that began while he was mowing his lawn 50 minutes ago. The patient has difficulty breathing and is diaphoretic. His vital signs are stable. Physical examination shows no acute findings. An ECG reveals the results below. Which vessel is most likely included in this patient? Okay, a couple things. Okay, number one. Everything on the boards is classic, okay? They're not trying to trick you. Like they say, a guy with high pretest probability for coronary disease, acute onset, and here's his EKG. The EKGs on the in-service and the boards are classic, okay? Again, while you're taking these tests, forget about all the stuff I teach you. Just go by what the book says. And when we look at this EKG right here, you can clearly see there's ST elevation in lead 1 and AVL, which consists of the high lateral infarct. We have reciprocal changes or depression in 2-3 and AVF. There's also a bit of J-point depression in V1 as well, so it consists with the high lateral. And the other thing you got to remember is, well, what are they asking? Okay, and they're asking which vessel is most likely included in this patient. Okay, number one, LAD. No, that doesn't make sense. That would be in the precordial leads. First diagonal branch of the LAD. Possible, okay, because everything I've read says, well, it's the circumflex, the first diagonal branch off the LAD. Is that also the circumflex? Possibly. Right coronary artery? No, that would be 2-3 and AVF because this is the boards and everything's classic. Posterior descending? No, that would be ST depression in the precordial leads because everything on the boards is classic. So I'm saying first diagonal branch of the LAD, which I think is kind of crappy because I'm looking for circumflex, but they don't put that. And the answer is diagonal branch. Excellent. Here's all the explanations which you can look through at your leisure. And again, like this is what I was talking about before. This test question is stupid. Like in real life, I don't care which vessel it is. Like all I care about is I'm identifying occlusion and I'm getting to the cath lab. It's dumb, but that's the way test questions are. Picture, yeah. All right, question number 2. EMS calls to say they're inbound with a 48-year-old male who has a witnessed cardiac arrest on the street. A passerby began chest compressions very shortly thereafter. EMS says upon their arrival, the patient was unresponsive and in fine V-fib on the monitor. Okay. They defibrillated once, which resulted in ROSC. En route, an IO is placed with 0.5 milligrams of atropine administered. EMS is attempting to intubate the patient who appears to have slow junctional rhythm with a weak pulse of about 30 beats per minute despite atropine. They ask how they should proceed at this point. This is a stupid question. Okay, so remember, what is the question asking? The question is asking, what should you tell EMS? Okay. Again, for these questions, like in the STEM questions, there's a common thing in the boards. They'll give you a bunch of information, and what they're doing is they're indirectly giving you the diagnosis. Okay, so let's look at this. 48-year-old dude with cardiac arrest and ROSC, okay? He's sick, right? Like what do they say? Appears to have slow junctional rhythm, weak pulse, about 30 beats per minute, okay? This is symptomatic bradycardia, okay? So this whole question should say, what do you do for symptomatic bradycardia? Like that's what the summary is, okay? I call these girlfriend questions. All right, no offense, but it's like talking to your girlfriend. They give you like 20 pieces of information and you have to decipher it. Well, what is actually going on? Okay, so we have a unstable bradycardic patient, and the question is, well, what should EMS do? Okay, A, proceed with atropine until a total of 3 milligrams have been given. That doesn't make any sense. Okay, begin transcutaneous pacing or epinephrine infusion. I like that one. Tell them since he has a pulse to observe for the effect of atropine. If no movement in his blood pressure, start amiodarone. That doesn't make any sense. Resume CPR since the rate is very slow and the pulse is weak. Nope, that's not true. Give epinephrine. I mean, yeah, you could do that. Or administer 1 liter normal saline bolus. See, this is what I hate about these questions. Like, well, how should you proceed? I would do many of these things at once. But the answer I think they're asking for is pacing, right? I mean, because they give you in the stem, like this guy's bradycardic, there it did atropine, it's not working, and he's got symptomatic bradycardia. Like, what should you do? You pace, okay? This is like an ACLS question. You go right to pacing. And this is different, again, from your practice, because in your practice, you're like, well, let's see if we can do this. What hospital am I at? Is cardiology in-house? Am I working at Toledo, Flower, Fostoria? Where am I? So in real life, it's different, okay? But the test question here, someone's unstable, you do what you need to do, you don't think about it, so you pace them. That's what my answer is, and it's correct, yeah. Here's the key concept. Again, when someone's unstable, you go right to the treatment. Like on the test, you go right to the treatment. Like you don't think about it. Like if they got a pneumothorax, you put a chest tube in. Like you don't wait and see what happens. You go right to the definitive treatment. Next question. A 35-year-old man with a history of intravenous drug use presents with fevers and chills for the past week. He states he also has progressive shortness of breath on exertion over the past few years, but has never sought medical attention. Okay. On physical examination, there is a medium, high-pitched, continuous murmur, best heard at the pulmonic position. Okay, with a harsh machine-like quality. A chest x-ray shows bilateral scattered infiltrates consistent with septic emboli. An echocardiogram reveals a normal aperic aortic valve with a dilated left heart. Okay. Blood cultures are persistently positive for streptococcus. Severe pulmonary hypertension is confirmed during right heart catheterization. Which of the following is most likely responsible for this patient's conditions? All right, this is also a girlfriend question, okay? They give us all this information, okay? They say he uses IV drugs, okay? He's short of breath. He's got a murmur, okay? And usually for the boards, so this is a key point for your in-service and your boards. The location of a murmur equals which valve it is. They're not going to trick you on that, okay? So normally they give you the position of the murmur, and the position of the murmur equals which valve it is. But here they help you out. They say, well, he's got a murmur with a pulmonic valve, okay? Chest x-ray, he's got septic emboli. So he's throwing septic emboli from somewhere. But they go on to tell us, an electrocardiogram reveals it's not his aortic valve, okay? So he's throwing septic emboli. It's not his aortic valve. And they go on to tell you again, yeah, like he's septic, like he's got streptococcus in his bloodstream. And he had a heart cath, and it shows pulmonary hypertension. So which of the following is most likely the patient's condition? Okay. Chronic PE, no, that doesn't make any sense. Aortic valve endocarditis, they want you to pick this one, because that would be the classic one. He's a 35-year-old guy who uses IV drugs, but they tell you in the stem that his aortic valve was normal, okay? Idiopathic pulmonary hypertension, no. Why would that be? I mean, this is acute onset. He's been sick. He's got a fever. He's got a murmur. Patent ductic arteriosus, I like that one. Atrial fibrillation, no. PDA, it's a PDA, okay? Because the other thing is, again, like this girlfriend stuff, you have to infer what they're telling you. A chest x-ray shows bilateral scaled infiltrates consist with septic emboli. So how did those septic emboli get over to the lung? The only way it can is that there's a connection between the two, and that's a PDA. Like this is a very good example of an in-service and a board question. They give you all this information. They want you to pick the classic thing, which is, endocarditis because he's an IV drug user, but they give you clues in there that that's not the answer. So they want you to think like one level removed. So I'm saying PDA. Yes, Patrick is crushing it. Here's the explanation for it, which you can read at your leisure. Oh, and here's what I was talking about. Okay, the location of the murmur equals where the valve is, and just remember this chart. And so I remember it's AP TM, right? Aortic, pulmonary, tricuspid, and mitral. And I remember this picture, and what I remember it's like a hand over the left side of the chest, like someone's trying to cop a feel on a breast, all right? And I remember it as a pervert touched me, all right? That's how I remember it. Aortic, pulmonary, tricuspid, mitral. And I picture like this hand coming over the sides of the breast like someone, like a pervert trying to cop a feel, okay? If you like that, great. If not, then don't listen to me. I don't care. But on the tests, the location of the murmur equals the valve. Like, don't overthink it. They're not going to try to trick you on that. Location equals valve. All right, a 63-year-old previous healthy woman is in a high-speed motor vehicle collision following an uncomplicated repair of a closed femur fracture. Her EKG becomes abnormal, showing 1 to 2 millimeters of elevation in V2 through V4 with deep T-wave inverge in V4, 5, and 6. And AVL. Troponin is elevated. You can tell how old this is, like they use the old troponins. She undergoes an emergent cath, which reveals no evidence of acute coronary occlusion. Which of the following additional findings is likely to be present? This is lame. I hate when they do this. All right, so let's look at what we got. So we got a 63-year-old lady who's in a car accident. She gets her femur fixed, okay? The reason this is in there is, I mean, you got to consider like a fat embolism, right? So they say her EKG becomes abnormal. And again, like same thing, they're not telling you what it is, but they're telling you, well, she's got a STEMI, right? We have elevation in contiguous leads with reciprocal changes, so we got a STEMI. So we got a lady in a car accident with a femur fracture, and now she's got a STEMI with elevated troponins, and her cath is clean, okay? Which of the following findings likely to be present? Multivessel high-grade stenosis, no. I mean, right? They told you that the cath was clean. Like, screw you. Ramus interremius, I don't know what that is, so we'll come back to that. Severe mitral regurgitation, that doesn't make any sense. Like, why would you have mitral regurgitation? They tell me nothing about a murmur. Akinetic left V apex, this is tempting. I like this one because I think what they're referring to is Takotsubo's left coronary bifurcation aneurysm. That doesn't really make any sense to me. Like, what here in the stem points to an aneurysm? So if I was taking this test question, I'd either say ramus intermedius or akinetic apex. I don't know what this means. And I think they're trying to get after Takotsubo's, right? Because again, they do this all the time. They give you all the diagnostic criteria for the diagnosis, but they don't tell you the diagnosis. Like they could just come out and say, hey, a lady has Takotsubo's, what else would you expect? But they don't say that. Like this is a common thing on the boards. They want you to think one step remove. So I'm saying D, akinetic left V apex because of Takotsubo's. Yeah. What does it say? Yeah, here we go. Stress-reduced Takotsubo's. Again, an important point, right? They do this again and again. They don't tell you the diagnosis. They tell you the criteria for the diagnosis, and they ask you a question one step to remove, which is dumb, but that's the way it is. Okay. 2-year-old patient is brought to the emergency department after an episode of tonic-clonic activity in their right arm. That doesn't make any sense. There is no prior history of seizure disorder. The patient has a low-grade temperature at home for several days and has not been eating well. Patient's cardiac exam reveals a 3 out of 6 whole stomach murmur. Okay, here we go. Murmur at the left sternal border. Left, that's a pulmonic. Okay. A complete blood count is significant for an elevated white blood cell count with a predominance of neutrophils. And EKG reveals ventricular septal defects with vegetations. All right. Which of the following is the next most appropriate step in management? All right, let's see. So you remember, okay, so what is, Patrick. Bear with me for a sec. Where are we at? We're at the kid. Where's the kid? 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 There's the kid. Okay, so we got a 2-year-old kid who comes in with a seizure. Okay, he's got an elevated white count and structural heart disease. Which of the following is the next most appropriate step in management? Again, this is dumb, okay? Most appropriate step is kind of a subjective term. And again, in real life, what I would do is different. Depends on what hospital I'm at, okay? An EKG, you're never wrong to do an EKG, but I don't know how that would help me here. An EEG, okay, that's to check for seizures. I'm tempted to make that too. Cranial MRI, I like this one, right? Like he's got a fever, he's got vegetations, he's got a atrial structural deficit. Like, how are these vegetations getting into the brain? I mean, because I think he's got a space occupying release in the brain causing his symptoms. I like cranial MRI. CT scan, I am tempted. I mean, a CT scan, I would probably do that as well. But again, what are they asking? Most appropriate step in management. So they're asking you, well, if you could only choose one of these, which would you choose? And I would choose MRI because that would give me the most information. CT scan, I mean, I would probably do that too, but an MRI is better. It's the gold standard. Lumbar puncture, no, I'm not doing that until after I do imaging. So I'm saying cranial MRI. CT, Patrick, what are you talking about? Congenital cardiac lesions can result in specific pulmonary. Okay, but why not an MRI? Oh, an MRI, but it's not as rapid as CT scan. All right, screw you. I hate you. All right, a good example of an exercise. Why I was wrong. A CT scan is faster. The boards and in-service suck, so whatever. 79-year-old male is admitted for atrial fibrillation with rapid ventricular response. He's been feeling short of breath for the past 4 days. His medical conditions include coronary artery disease, chronic heart failure. This is a girlfriend question. Here we go. Left ventricular ejection fraction 25, hypertension, diabetes. C. He takes aspirin, metoprolol, simvastatin, Lasix, and insulin. Girlfriend question. They're giving you all this information. You have to figure out, well, what part of it is relevant. The metoprolol has now been increased to its maximum dose, but the heart rate has only reduced from 130 to 140 to 110 to 120. He remains hemodynamically stable. Okay, so he's stable. Chest x-ray is normal. Which of the following is the most appropriate next step in management? Appropriate next step. I hate these. Cardioversion, I'm tempted, but they tell you he's hemodynamically stable, so I'm not going to do that. Cardizem, I'm tempted, but I'm not going to choose it. I know why, but we'll talk about that later. Amiodarone, again, is also, I mean, you can use that as an antiarrhythmic and stuff like that. And DIG, I mean, DIG, is an appropriate possible option in real life, okay? What I am choosing for, now here's the key, okay, girlfriend question. They give you all this stuff, and again, think about, well, what do we have? We have a stable patient with AFib with RVR who is not controlled on metoprolol. We're going to start other rate-controlling medications, but one of the things you need to think about in these people is what's their ejection fraction, okay? Cardizem, they want you to choose cardizem, but that's not the answer because he's got a low EF, okay? Like a low EF, you shouldn't use cardizem on them because it's going to make them worse. Again, a girlfriend question, like what's the main concept here? The concept is cardizem you should use with hesitation. People have a low ejection fraction. So for this one, I'm choosing DIG, because DIG also helps your heart pump. It's like got inotropy things. It also helps your heart pump like harder. So that's what I'm saying. Please be right. DIG, yeah, all right. Again, you can read through the answers at your leisure. All right, 50-year-old male with a history of myocardial infarction 6 days ago presents to the emergency department reporting shortness of breath and dizziness. The patient was walking around his neighborhood when these symptoms began 1 hour ago, so acute onset, preventing him from walking any further. His wife immediately took him to the hospital. Vital signs show he's hypotensive and tachycardic and hypoxic. On examination, a murmur. The left fifth intercostal space. So what is that? A pervert touch me. That's mitral valve, but not elsewhere. Which of the following is the most likely diagnosis? Okay, so again, same thing. They give you all of the information, but not the diagnosis. This guy had a heart attack. Now he's got a mitral valve murmur. He ruptured his papillary muscle wall. That's what he did. All right. So which of the following is the most likely diagnosis? Intraventricular septum rupture. I mean, that's possible in the time frame, but that doesn't make sense with his presentation. Like he should be like super sick and the murmur. Free wall rupture, same thing. Like he would not be in the hospital if his free wall ruptured. Aneurysm formation with thrombus dislodgement. No, that doesn't make any sense. Okay, here we go. Acute mitral regurgitation. Yes, from papillary muscle wall rupture. That's what I'm choosing. End of story. And that's what it is. Here's the answer, which you can read through. All right, 17-year-old man with a history of CHF presents to the ED with shortness of breath over the past few days, running out of his medications at home. Okay, so gradual onset of shortness of breath. Vital signs are notable for a heart rate of 103 and blood pressure of 95 or 60, respiratory of 25, and expiration of 89. So he's tachycardic, hypotensive, and a little hypoxic. Exam is notable for coarse crackles over both lung fields and prominent JV pulsations. Okay. The patient is started on dobutamine for inotropic support with significant clinical improvement. Okay, that's good. Which of the following describes his hemodynamic changes after treatment? This is stupid. So, this is really dumb. All right, so number one, I have no idea. Okay, number two, this test question is put in there to help stratify all of you guys. Okay, these tests are like a obstacle course. Okay, so imagine if you had 100 people running an obstacle course, and the obstacle course was just a bunch of 1 foot walls after each other. Like everyone would get through that obstacle course, right? But let's say every now and then you throw in like 1 10-foot wall, well, that would make it more difficult. This is a 10-foot wall question. Like it's supposed to help differentiate like everyone between each other so they can rank you, because that's what this is all about, is giving a number to your program as far as what tests are. So in real life, I'd be like, I have no idea. I'm going to skip this and come back later. Okay. So after I did all my other questions, I would come back to this one and I would try to figure it out. Okay. So we got a guy, AFib or CHF. Okay. They put him on dobutamine. And the question is, which design describes his hemodynamic changes after treatment? This is bullshit. Okay. A, increased left ventricular end systolic volume. Let me think. Increased end systolic. So after it's done filling, there'd be more volume. That doesn't make sense. Increased left ventricular end diastolic volume. So this says after it's done filling, there's more volume. No. After it's done emptying, more volume. No. I don't like either one of these. And these are tempting because in general, in the boards, when you have two answers that are similar but opposite, it's usually one of those. I mean, I think they know that. They're trying to trick you. Neither one of these makes sense. Shortened width of the left ventricular. What? Shortened width of the left ventricular pressure volume loop. I have no clue. Steeper end systolic pressure volume relationship. All right. Okay, so when you're working through these, my other piece of advice is try to eliminate what you can. So I don't think it's A or B. So now I'm down to 50-50. So I have a 50% chance of getting a point. Let's look at these. Shortened, I don't even know what that's saying. Steeper end systolic pressure volume relationship. Okay, let me think. So end systolic. So at the end of when it's pushing, a steeper pressure volume, meaning that for every amount of volume you got to be pressure, I don't think so. That doesn't make sense. Shortened width of the left ventricular pressure volume. Shortened width of the pressure volume loop. So pressure, so volume shortened width. I'm gonna guess C. I have no idea. D. Oh, Patrick. All right, whatever. I would just take that. I'd be like, yep, that's a loss for me. I'm not going to get that right. And I'm okay with that because never in my life have they been like, what's happening with this pressure volume loop in room 13? Like, that's never happened to me. And I'm okay with it. Here's their example, whatever. I'm just going to take that as a loss on the test, to be honest. A 46-year-old man with a history of atrial fibrillation undergoes a successful ablation procedure is admitted for monitoring overnight. After the procedure, the patient is asymptomatic and he will be stable with a normal sinus rhythm. Good. By the following morning, he is increasingly short of breath. Not good. Vital signs are notable for tachycardia and hypotension, and he's hypoxic. Physical exam reveals distant heart sounds with JVD. Oh, this is an easy one. Okay, so there'll be a common thing between like pericardial tamponade, tension pneumothorax, and hemothorax. And again, they'll give you like the classic thing. So distant heart sounds in JVD, but they'll say, well, his lungs are clear because that like leads you to believe that's tamponade. They'll say he's got abnormal lung sounds if it's pneumothorax. Okay, so which of the following findings is expected? I hate you. Okay, unilateral decreased breath sounds, no. All right, so that's what they want you to pick if it's a pneumothorax, which he doesn't have. I mean, he just had ablation done. All right, fixed splitting of the S2, maybe. S3 gallop, no idea. Obliteration of the pulse with inspiration, okay, yeah. Harsh diastolic decrescentic murmur, same thing. So I'm picking this, all right, because this is pulsus paradoxus, and same thing. This is a common thing, right? Like this question could say, is pulsus paradoxus associated with tamponade? Oh, I was right. Okay. And the answer is yes, but they're not asking you, they're not telling you that. They don't say, hey, this guy's got a pericardial effusion. They give you all the history leading up to it. They don't say, hey, is a pericardial effusion associated with pulsus paradoxus? No, they put this other crap in here. So this is a common thing. Like, that's the thing is you know the diagnosis and you know the answer, but they just change the words around, so don't get freaked out about it. Okay. Like, again, these tests are just game. It's all about like the way you think. Okay. Here's the answer for this one. All right, next one. 6-year-old man with a history of pacemaker placement presents after an episode of syncope. The patient states he was typing an email to his wife when he suddenly lost consciousness and woke up on the floor. These women are always trying to kill us, even electronically. He did not sustain any head trauma and is currently asymptomatic. What is the most likely cause of his syncope? Okay, we got pacemaker with syncope, battery depletion, hardware infection, oversensing, undersensing, wire fracture. All right. So let's look through this just off the bat before we even get started. Remember what I said, if you have two answers that are opposite each other, it's most often that. So I think this is probably an oversensing or undersensing question, but let's go through. Okay, battery depletion, that doesn't make much sense, right? Because he was just sitting there typing and all of a sudden he woke up, he went out, and now he's currently asymptomatic, like completely asymptomatic. If it was battery depletion, he should still be symptomatic. Hardware infection, they give me nothing about infection in the stem. Like there's no fever, there's no white blood cell count, there's no nothing, so I don't think it's that one. Oversensing or undersensing, I think it's one of those two. Wire fracture, again, they give you nothing in the history for wire fracture. So it's either oversensing or undersensing. Everyone gets these complicated. It's a simple fact, okay? And they're opposites. So a pacemaker does two things. Number one, it senses. Number two, it fires. Oversensing and undersensing, the definition is just opposite, okay? Oversensing is underfiring. Undersensing is overfiring, okay? So we have a guy who was on his computer and passed out. Do you think it's oversensing or undersensing? Well, oversensing is underfiring, so I think it's oversensing. That's what I think the answer is, and it is the answer. And here is their thing, or is it bad? Yeah, again, see, like it doesn't make sense. Like they give you stuff in the stem and you have to like defer what's going on. All right, a 56-year-old male presents complaining of 30 minutes of crushing substernal chest pain. 10 minutes after arrival, his EKG shows evidence of an anterior wall STEMI. You are not at a center that offers PCI. Normally, you're able to fly a patient to a center 20 minutes away. However, the weather presents flying, and the center is 60 minutes by ground. It's a time question. What is the most appropriate therapy for this patient? Okay, so we got a patient with a STEMI who I'm transferring. What's the key concept? The key concept is 120 minutes. Like if you can't get him to the cath lab in 120 minutes, you have to give him thrombolytics. So what's the time here? So we got 60 minutes by ground, and he's been having pain for 30 minutes. 60 plus 30 is 90, so we're not at the 120 yet. So what is the most appropriate therapy for this patient? Let's see. Administration of fibrolytics, no. They're trying to trick you, right? Like they want you to freak out because of delay. And they're like, oh, you got to give them thrombolytics, but they're trying to trick you because the time is 120. So thrombolytics, no. Administrative thrombolytics and transferred PCI. I mean, this is an option, okay? Because, I mean, the data shows you can give thrombolytics and then do a PCI at the same time. I mean, there may be a slight increased risk of bleeding, but it's still a safe and appropriate thing. So that is technically an option in the real world. But they're trying to trick you because this test is stupid. All right, immediate transport to PCI, yes. Like, that's what they want you to choose. Wait 60 minutes for weather clear transport, and if not, what? That's stupid. All right. So I'm saying C, immediate transport, and they're trying to trick you here, right? Like they're like, ooh, there's a delay in transfer. Why don't you give them thrombolytics? Oh, but it's still within the 120 time frame, so you're not supposed to. I think that's what the answer is, and that's what it is. See, these test questions are just games. Okay, like once you understand the rules, yeah, there we go. There's all the answers you can read. Which of the following arrhythmias confers a poor prognosis on the patient with acute myocardial infarction? Complete heart block and an anterior myocardium. That's bad. Sinus bradycardia, not so bad. Ventricular fibrillation within an hour of the infarction, not necessarily. That could be reperfusion. Ventricular tachycardia within an hour of the infarction, no. I'm saying complete heart block. Yeah, that was an easy one. Okay, there's the answer. A 46-year-old is evaluated for syncope after reporting 3 weeks of progressively worsening dyspnea on exertion. They were previously physically active and ran 1 to 2 miles daily. They can walk only 5 blocks before stopping due to shortness of breath. They endorse intermittent chest tightness, denies fevers, chills, and chest pain. The past medical history is unremarkable. They currently take no medications. They have no sick contacts. Their travel history is notable for camping in New Hampshire 2 months ago. New Hampshire. So again, a girlfriend question, right? They give you all this crap, and what's important is he was at New Hampshire. Like, screw you. On physical examination, the vital signs notable for a heart rate of 41, so he's bradycardic. The heart rate is slow but regular. There are no appreciable murmurs. That's good. The lungs occlude auscultation, the skin evaluation unremarkable, the remaining examination non-contributors. We got a symptomatic bradycardic patient who was in New Hampshire. Laboratory studies, hemoglobin 14.3, creatinine 1, troponin. There we go. Borrell-Berger-Fergie positive. An electrocardiogram is showed which the most. Okay, so we got someone with Lyme disease. Lyme. He was in New Hampshire. He's positive for Borrelia. He's bradycardic. So I'm expecting some kind of heart block. Let's see what you got for me, bro. Yeah. Okay, let's look at this. I'm calling this, there's P, QRS, P, no QRS. So I'm calling this a second degree type 2 because the PR signal stays the same. And you can make the argument that's a complete heart block, but the short of the story is he's symptomatically bradycardic, right? All right, so we got, remember, so what are they asking? They're asking what's the next step in therapy and what do we have? We have a patient with a heart block from Lyme disease. Intravenous doxy, no. Vancomycin, no. Oral Cephin, no. He's got a heart block. Intravenous Rocephin, yes. Oral doxy, no. And again, like, they're trying to trick you again, because remember, if you see two answers that are opposite, sometimes that's the answer, and they know that I know that, so they're trying to trick me. So they want you to be like, oh, doxy. We usually use doxy for Lyme, but he's unstable. He's got a heart block, so he needs Rocephin. That's my answer. Yeah, that's the answer. Yeah, here we go. All right, 2-to-1 AV block. Yeah. Again, remember the EKGs on the tests are classic. Okay, here we go. 55-year-old male with a past medical history of atrial fibrillation presents ED after an episode of syncope. In the ED, another episode of syncope occurs and a rhythm strip is taken below. Dope. Okay. The patient on several cardiac medications. Which of the following medications will cause the arrhythmia? So what do we have here? We have a wide complex rhythm. This is technically like a polymorphic ventricular tachycardia. This is kind of a crappy question because, in real life, you have to, well, is this torsades from prolonged QT or is this polymorphic ventricular tachycardia from ACS? And you only know that by determining what the QTC is. You can't really see the QTC here is. But again, girlfriend questions. They give you hints, okay? Let's see. He's on several cardiac medications, okay? What's the most common cause of a prolonged QT in torsades in America is medications. So that's what they're trying to trick you, okay? So which of the following medications more likely cause the arrhythmia and which one of these prolongs your QT? And it's sotalol. That's what it is, okay? Cardizem, Ditazin, and adenosine, they don't prolong your QT. Sotalol does. This is, again, a crappy question because in real life, whether this is polymorphic VTAC from ACS or torsades depends on what the QTC is, and they don't give you the QTC, but they're telling you indirectly it takes a bunch of meds. So they want you to know that the most common cause of prolonged QT is meds, and you have to differentiate that, right? Again, like girlfriend questions. Like they give you the information, you have to infer what's going on. Please let me be right. Yeah, sotalol. And there's the answer. All right. 60-year-old male is admitted to the hospital for anasacker and dyspnea that have increased over the past 3 months. He is obese with diabetes and hypertension. Medications include, oh, God. Aspirin, lisinopril, atorvastatin, insulin, vital signs, normal temperature, little tachycardic, little hypotensive, tachypnic, okay. And physical exam, there's right ventricular heave and JVD, okay. Lungs occlude auscultation, diffuse anasarcas, no lower extremities, and abdomen, and ECG does not indicate ischemia. Labs, sodium 135, potassium a little high, chloride 98, bicarb 22, BUN 60, and a creatinine of 2.4. His previous creatinine level was 0.9 1 year ago. Over the past 12 hours, diuresis has been attempted with different agents, but urine output has not increased. Which of the following is the next step in management? Okay, which of the following is the next step in management? Stupid question. What are they giving us? They're giving us someone who's got a flare-up of congestive heart failure. That's what they're giving us. So we got someone with CHF. We're trying diuretics, and it's not working. So what's the next thing we should do? Okay, continue diuretics. That's stupid. I mean, they already told you diuretics are not working, so why would you give more diuretics? Beta blocker, that doesn't make any sense to me. Okay, why would I start a beta blocker? Like, he's not really tachycardic. He was only like a 95. Vasopressor, I'm tempted for that one. I mean, because it's almost like he's symptomatic hypotension, like vasopressor. That's a possibility. Start an inotrope. I want that one. Yeah, inotrope. Before I go straight to a vasopressor, I'm going to try an inotrope because he's not that sick. And again, this is a common thing they give you, like, say the person's in CHF and he's not crazy sick, So what should we do? And I'm saying inotrope, but I'm between vasopressor. I'm going inotrope. I think vasopressor is too much. Like they're not painting enough of a sick picture for me to go vasopressor. Please be inotrope. Yeah. All right. Why not beta? Why not vasopressor? They say vasopressor can increase vascular resistance, but do not increase perfusion to the kidneys. Again, girlfriend question. They gave you his kidney function is worse. All right, good. I didn't know that, but I still got the right answer. All right, 55-year-old male with a history of hypertension, hyperlipidemia, and diabetes presents with new onset shortness of breath for the past 3 days. He underwent mechanical aortic valve replacement for stenotic bicuspid aortic valve 3 months ago, and his INR is in the 2-3 range. He reports dizziness on standing and has to stop more often when walking. He can speak in full sentences, but but prefers to have his bed propped up. Okay, so we got a CHF issue. Vital signs are significant for a heart rate of 100, blood pressure 155 over 40. There is a normal S1 and muffled S2. I don't know what to do about that. A 3 out of 6 systolic murmur, okay, and a 2 out of 4 diastolic murmur are heard at the left sternal border. So okay, the third and fourth intercostal space. His perfusion is normal. These findings are new compared to his last image 2 days. Let's go. EKG does not clearly visualize, an echo doesn't. You can't see the aortic valve, but suggests a peak grading of 30. Which of the following is the next best step in management? Oh, God. Okay, so what do we got here? We got a 55-year-old guy who is short of breath, and he had valve replacement. Now he's got a new murmur, so his valve is jacked, okay? They say his Coumadin is good. They don't point an infectious picture, so he's got a jacked up valve, but no infection, so what should we do next? Valve surgery. I'm tempted. I mean, I would probably be talking to his surgeon right off the bat, but I don't think sending right to the OR is what to do. Diagnosis valve fluoroscopy, I like that one. Coagulation, no. I mean, we don't have to coagulate him because his INR is good. Cardiac catheterization for coronary artery assessment. Why would we do that? He's got a valve problem. I mean, I would order an echo, but that's not on here. So diagnostic valve fluoroscopy is what I'm choosing. And that's right. And here is their explanation that you can read at your leisure. All right, a 40-year-old woman presents to the emergency department with a fever, trouble breathing, and cough for 2 days. She also has chest pain that is worse with inspiration, but which is partially relieved by leaning forward. Okay, she's febrile with otherwise normal vital signs. Field exam reveals a friction rub at the left sternal border. We got pericarditis going on here. While leaning forward, which pathogen is most likely to cause this patient's symptom? Okay, again, stupid question. Again, look at the stem. They're telling you she's got pericarditis without telling you she's got pericarditis. Like they don't come out and say, hey, it's pericarditis. They give you the diagnosis criteria for it. So again, this common thing, they give you the information. They don't ask you a simple question. They ask you one removed. So you got someone with pericarditis. This is an infectious question. Well, what's likely causing it? Oh, God. Again, I would skip this one and come back. I don't know any. Toga virus. I have no idea. Never heard of that. Picorhinovirus. What is that? Sounds like a Pokemon. Paramyxovirus. We got a bunch of Pokemon here, and flavivirus. I have no idea. I've never heard of togavirus or flavivirus. So I like picorhinovirus and paramyxovirus. I can't remember these ones. I haven't been studying. I'm guessing B. Let's guess with B. Let's see. Oh, yeah! Because I thought it was like Coxsackie virus that caused it. And again, but they don't give you Coxsackie virus because that'd be too easy. What do they say? Coxsackie is a positive for pico. This is what I'm talking about. This is a 10-foot wall question. Like you need, like to get this right, you need to know that Pico viridale is a member of the like that's dumb, all right? But again, like that's the way the test is, and you just have to suck it up and do it. 35-year-old man presents emergency department with palpitations after cocaine use. Awesome. The patient has had similar episodes in the past that resolved spontaneously. He denies shortness of breath or chest discomfort. Vital signs are normal for a heart rate of 160 tachycardic. He's hypertensive. EKG shows regular narrow complex tachycardia without discernible P waves. He's an SVT. The physician applies firm pressure to the lateral of the neck, which quickly leads to resolution of the patient's symptoms and restoration of sinus rhythm with a rate of 75. Okay, vagal maneuvers. See, this is why I hate this stuff. They just say, hey, he's got SVT with vagal maneuvers. That's all you can have to say. This intervention was effective due to which of the following? Oh, this is dumb. All right. decrease efferent activity to the, I have no idea. Increase efferent activity to the 9th cranial nerves and increase to the 10th. No idea. Decrease efferent to the 9th, afferent. All right. I have no clue. I would skip this one and come back. Let's see if we can figure it out. So efferent means it's going back to the brain, right? So decrease. So I don't think it's so decreased efferent. I don't like that. I don't like decrease, or decrease. So I'm getting rid of these decrease. Okay, so we got two increases. Increase afferent activity to the 9th cranial nerve. Increase afferent to the cranial nerve, 11th nerve. I can't remember which one of these was. It's one of these two because you're increasing to the vagal nerve. I'm not sure which one vagal nerve is. Oh, I'm between B and D. I'm going to choose D because this one's, well, I take it back. I'm going to choose B. This is a Sesame Street one. Like, which one of these ones is not like the other ones? Like, all these ones, like, see how they're short? This one has the next one. I'm choosing D. I'm choosing B, but I got a 50% chance. Let's see. Yeah! Suck it! Here's the answer, which I'm not going to remember or think about ever after this video or a test. All right, 42-year-old man presents the emergency department with chest pressure that has been going on for the past 6 months and associated with moderate physical activity. These symptoms do not occur at rest. The patient has diabetes type 2 and hypertension, which are diet controlled. He has a 30-pack year history of smoking, but quit 2 months ago. Good for you. But his only medication is aspirin. His vital signs are slightly hypertensive, good rate, respiratory is okay, exercise is okay. Lungs are clear, auscultation by layer without dullness. The remainder of the physical exam is normal, and ECG shows LVH with diffuse ST and T-wave borderline abnormalities. Laboratory values are sodium 142, potassium 3.6, chloride, bicarb, BUN, creatinine, hemoglobin A1C, troponin. Yeah. Which of the following is the next step in management? God. All right, so what do we got? We got a 42-year-old guy who's got, sounds like stable angina. Okay. He's high risk. Like, he's a diabetic. He's a smoker. His troponin's normal. Okay, so we got, sounds like stable angina. What's the next step in management? Chest x-ray, I don't know. Stress, yeah, I like that. Nuclear stress, I like that as well. Bronchodilators, no. So it's not chest x-ray, it's not bronchodilators. Again, another thing that happens, two answers are very similar. Which one is it? Either stress echo or nuclear stress. I would choose nuclear stress. I mean, because I think that's a better test, right? Again, like for me, this is a pretest probability thing, right? The guy's got like a high pretest probability. He's a lot of risk factors. I wouldn't trust a stressed echo, so I'm going to nuclear. Oh, the other thing is he's got an abnormal EKG, right? Like, he's got an abnormal EKG. A stress echo is like, well, you're looking at the EKG to see what happens. So I'm choosing a nuclear stress. Please be right. Yeah, nuclear stress. Here's the answer. Why not a stress echo? Because of the LVH and EKG changes, right? Okay, I got you. All right, 55-year-old male with a history of hypertension, hyperlipidemia, and diabetes presents the emergency department due to new onset chest pain that started while gardening 1 hour ago. He has known hypertrophic obstructive cardiomyopathy and has had an ICD placed. Okay. The patient's pain is sharp, left side, right down the back. Upon physical exam, he's tachycardic, he's hypertensive. He reports continuing chest pain. 2 out of 6, murmur at the left lower sternal border. That's tricuspid, which increases with Valsalva maneuver. An EKG shows a irregular rhythm. Okay, so he's an AFib. New ST elevations V1 and V2. His troponin is elevated. He's admitted with a diagnosis of an anterior acidic myocardial function. Prepared for catheterization laboratory. In treating his acute hypertension, which of the following medications will achieve the greatest reduction in myocardial oxygen? All right, so we got a guy with a STEMI and some type of structural problem. So which is greatest reducing myocardial oxygen demand? Nitroprusside, DILT, lisinopril furosemide, hydrochlorothiazide. I'm saying nitroprusside. That's what I'm saying. Diltiazem is a calcium channel blocker. That won't really reduce the risk for myocardial oxygen demand. Lisinopril, no. Lasix, that doesn't make any sense. Doesn't make sense. I'm saying sodium nitroprusside. Please be correct. Diltiazem. Why is that wrong? So this is the other thing, how I learned when I was studying, right? Like, I go through the test question and get the answer wrong. So what's the answer? So why are they saying diltiazem? Okay. Acute coronary syndrome. with hypertrophic cardiomyopathy, primary goes to reduce myocardial oxygen. In this particular case, is critical to decrease the heart rate. Okay. Naturopathic can control hypertension through systemic meds, but will not address the tachycardia. That's why. Damn it, Patrick. All right. Well, that's how you learn. That's how you study for these tests. A 60-year-old male with a history of coronary artery disease, hypertension, and smoking is brought to the emergency department with severe midline abdominal pain. Ooh, it's his aorta. The patient started acutely 30 minutes ago and is not associated with nausea or vomiting. His vital signs are normal for he's tachycardic and hypotensive. Abdomen's distended and tender. Yeah, he's got AAA. He's a pulsatile abdominal mass with poor perfusion. Yeah, he's got AAA. Which of the following describes the patient's underlying pathology? God damn it. This is dumb, right? Like they don't say, hey, guy's got a AAA. It's all this second remove things. Okay, so segmental full thickness arterial dilation. I like that one. Separation of the intima. No, that's a dissection. Full thickness gastric ulcerated perforation. No. Cellular infiltration of the aorta. No. Mesenteric. No. It's full thickness. Yeah, suck on that one. All right. A 25-year-old man with Down syndrome. Oh, shoot, what time is it? Oh, curses, I got to get ready for work. I hope you guys enjoyed this one. I know your test is coming up. My main piece of advice for you is remember, this is a game, okay? Once you understand the rules of the game and play by the rules, you'll do much better on your test. Any questions, ask me in person. I hope you guys do well. Peace, I'm out.